This is going to be the start of our cyanotic congenital heart diseases, as well as some medications and some, basic overviews. We're going to start with cyanotic lesions have a decreased pulmonary blood flow, which means that not enough blood reaches the lungs. This can cause chronic low oxygen, and we're going to see blue skin and fatigue. And with this, oxygen alone is not going to fix it because the heart defect is what needs to be repaired. So, cyanotic lesions with decreased pulmonary blood flow, the definition, these defects occur when there is an obstruction, a malignancy, or underdevelopment like hypoplasia and the right side of the heart. This reduces or blocks blood flow into the pulmonary artery and therefore less blood reaches the lungs. Your pathophysiology, we'll discuss them as we go through each of them. So a little trick to remember, there's 6 cyanotic heart defects. So the first one, number 1, is your trunctus arteriosus. And instead of having 2 great vessels leave the heart, we only have 1 great vessel leave the heart. So that's why we use one finger to represent it. The next one is the transposition of the greater arteries. So the 2 vessels that leave the heart are actually crossed over. So if you cross your fingers, if you make you cross your 2 fingers over, that's to represent the transposition of the greater arteries. I could not find 2 fingers crossed. I could only find 2 fingers, but that'll represent 2. 3 fingers is going to be your tricuspid valve. And with this, your tricuspid atresia, we have a failure to form the tricuspid valve. Tri stands for 3, so that's why we use 3 fingers. Next one is tetralogy of Fallot. Tetralogy of Fallot is probably one of the highest NCLEX tested heart defects in kids. It's really important to know, and it has 4 separate defects. That's why we call it tetralogy, because there's 4, so we use 4 fingers for it. And then 5 is our total anomalous pulmonary venous return. 5 words, so we use 5 fingers. And then once you have 5 fingers up, you can close your hand, and your whole hand can stand for your hypoplastic heart. So we're going to start with our truncus arteriosus. Truncus arteriosis, instead of having two great vessels leaving, so an aorta and the pulmonary, it just goes into one. So one large vessel instead of a separate pulmonary artery and aorta. It's always associated with a VSD, and blood from both ventricles mixes in that common vessel and then enters that systemic pulmonary coronary circulation. So your clinical signs are going to be cyanosis, congestive heart failure, and poor growth. Management is going to be a surgical repair where we're going to close the ventricle septal defect and we're going to reroute our tracks to divide them out. The next one is the transposition of the greater vessels. So in the transposition, the aorta arises from the right ventricle and the pulmonary artery arises from the left. This means we have 2 circulations and they're completely switched. So your normal blood flow is a loop where it goes from the body to the right heart, to the lungs, to the left heart, back to the body. In this, we have 2 separate but parallel circuits. So it goes from the right heart to the aorta to the body. And we have a continuous circulation of deoxygenated blood. The other circuit is the left heart to the pulmonary arteries to the lungs. And this is just oxygenated blood that recirculates. No oxygenated blood reaches the body unless there's an area of mixing, and it's usually a PDA, an ASD, or a VSD. Without that mixing, transposition of the greater arteries is incompatible with life. And this is just an image to kind of show you the two separate circuits. So in the standard heart, we come into the right, we go into the right ventricle, we go into our pulmonary arteries, we go to our lungs, we come back in through the pulmonary vein, we enter the left atrium, we go to the left ventricle, we go out our aorta, and we go to the body. With this, we're just going right, we're coming in, we're going into the ventricle, and we're leaving the aorta and going to the body. And from the body into the right atrium to the right ventricle and out the aorta. And then another circuit is going to be from the pulmonary into the left atrium to the left ventricle and then back out to the pulmonary. So one side is all oxygenated, one side is all deoxygenated, and we have to have, this is showing you the PDA right here. So if they have the PDA, there's going to be a mixture of oxygenated and deoxygenated blood. So a little bit of oxygenated blood will go out to the body, but it's not much. They can also have an atrial septal defect. So up here in our atriums, we have a hole, or a ventral septal defect. Obviously, if they have a PDA, an ASD, and a VSD, we'll have more mixing than if they just have one. So what's our manifestations of this going to be? Well, this is going to be cyanotic within a few hours of birth. And this is going to be a cyanotic baby that no matter how much oxygen we give them, they're just not going to pink up. They're going to be tachypnic, they're going to have respiratory distress, they're going to have poor feeding, lethargy, failure to thrive. We might have a murmur. Complications if untreated, we're going to go from severe hypoxemia to acidosis to shock and death. So our management, prostaglandin E1. We have to keep that PDA open for mixing. If they have an ASD or a VSD, we might go in and try to do a septoplasty where we actually enlarge that opening until we can do our definitive treatment, which will be switching the greater vessels to their correct positions. So as a nurse, you're going to monitor oxygenation, perfusion, and a lot of family support. This is really a critical situation. And baby's just born, things aren't going well. So your key takeaway in the transposition of the greater arteries, the body and the lungs run on separate loops. Oxygen never gets to the body unless there's a hole, and we have to keep that hole open. Babies are going to be very blue right after birth. They're going to need prostaglandin, emergency procedures, and surgery to survive. Tricuspid atresia. So tricuspid atresia means that the tricuspid valve, which would be your valve between your right atrium and right ventricle, did not develop. Because there's no opening, blood cannot go from the right atrium to the right ventricle. And with this, the right ventricle is often very small and hypoplastic. So the pathophysiology, blood returning from the body enters the right atrium, but cannot go to the right ventricle. It must pass through an ASD or a patent foramen ovale into the left atrium. From there, blood mixes, so we get oxygenated and deoxygenated blood, and goes into the left ventricle. To get blood to the lungs, the baby usually needs a VSD or a PDA so that blood can reach the pulmonary artery. Mixing is essential for survival. Your clinical manifestations, again, this is going to be a blue baby at birth, so cyanosis at birth, tachypnea, respiratory distress, poor feeding, fatigue, failure to thrive, clubbing of the fingers, toes, if it's a little bit older of an infant, heart murmur, complications if untreated, severe chronic hypoxemia, polycythemia. So what the body will do is the body will start to produce extra blood cells because if it's seeing that my tissues are not getting enough oxygen. And therefore, it's going to say, I'll make more red blood cells so I have more oxygen carriers. So we'll get a polycythemia, too many red blood cells, which puts the child at an increased risk for stroke and clotting issues. They can get heart failure and they can get death in infancy if not surgically managed. So, prostaglandin E1 is necessary to keep that PDA open so that we have mixing. We can do the septoplasty where we open up that atrial septum a little bit bigger if that's there. We can do surgery, which is done in stages. The first stage is going to be for the systemic pulmonary shunt, and that's done in the newborn period. Then we can do our Glenn procedure where our SVC is connected to our pulmonary artery. And then the last one is the Fontaine procedure, which the systemic venous blood is routed directly to the pulmonary arteries. This child is going to require lifelong cardiology follow-up. As nurses, we need to monitor oxygen levels, perfusion, growth, and educate families about the stages of surgery and cyanosis management. Key takeaways in tricuspid atresia, the valve from the right atrium to the right ventricle is missing. Blood cannot go to the right ventricle, so it has to mix through the holes and requires a PDA to reach the lungs. Babies are very blue at birth and need prostaglandin and stage surgeries to survive. Tetralogy of flow is the most common cyanotic congenital heart defect. It's called tetralogy because it has 4 problems together. Your 4 defects are pulmonic stenosis, so the narrowing of the pulmonary valve, which blocks blood flow to the lungs, a ventricular septal defect, which is that hole between the right and left ventricle, an overriding aorta, which means the aorta sits right over the VSD, pulling blood from both ventricles, and right ventricular hypertrophy, which is going to be that thickened muscle from pumping against the obstruction. Because of the narrowing, blood has trouble reaching the lungs. Pressure builds up in the right ventricle. Blood is pushed through the VSD into the left side, and we have a right to left shunt. This means deoxygenated blood mixes into that systemic circulation, causing cyanosis. Your clinical manifestations are cyanosis, which you're going to see worsen with crying or feeding, a harsh systolic murmur. Often they have TET spells, which are hypercyanotic episodes, and we'll see more of that on the next slide. Children may squat intrinsically for increased systemic vascular resistance and to improve oxygenation. We'll have poor feeding, fatigue, failure to thrive, clubbing of fingers and toes in older children. Complications, chronic hypoxemia leads to developmental delays, polycythemia, which puts them at an increased risk for strokes and clots, and severe TET spells can lead to death if not treated quickly. So our TET spells, also called hypercyanotic spells, are episodes common within the first 2 years of life, more seen in the morning, and they truly indicate that we need to do a surgical repair. Signs, we're going to have rapid deep respirations, irritability and crying, peripheral vasodilation, increased systemic venous return, and increasing cyanosis, and a decrease in systolic murmurs. They can be fatal, and if they have frequent or prolonged episode, it can lead to an ischemic brain injury. So anoxic. Management, immediately, we need to calm the child during the TET spells. Then we place the knees to the chest. We want to give them oxygen, morphine, and fluids as ordered. Prostaglandin in newborns can help keep that PDA open. Surgery, we do a palliative shunt in infancy, and then a definitive repair, closing the VSD, relieving pulmonary stenosis, usually within the first year of life. Nurses need to monitor oxygen saturations, feeding tolerance, growth, and educate family on recognizing TET spells and when to seek emergency care. So, tetralogy of flow, key takeaways. It has 4 defects: pulmonary stenosis, VSD, overriding aorta, and right ventricular hypertrophy. Babies turn blue because blood bypasses the lungs. They can have cyanotic TET spells and need surgery to survive. Total anomalous pulmonary venous return. So the pulmonary veins connect abnormally to the right atrium systemic veins. Oxygenated blood returns to the right side and mixes with the systemic venous blood. They need to have an ASD or a PFO for survival. Your clinical signs are going to be cyanosis, respiratory distress, heart failure. Management is surgical repair in infancy and lifelong follow-up. Then our final one is our hypoplastic left heart syndrome. So with hypoplastic left heart syndrome, this is going to be a severe congenital heart defect where the left side of the heart is underdeveloped or absent. The left side cannot pump blood into the body. So your pathophysiology, the right ventricle becomes the main pumping chamber. The blood from the right ventricle goes both to the lungs and through the ductus arteriosus to the body. Survival depends on the PDA staying open so systemic circulation can be supplied. If the ductus closes, we have shock, acidosis, and death. Clinical manifestations. Symptoms usually appear within hours to days of birth, especially as the ductus begins to close. We have cyanosis, weak or absent pulses, cool extremities, poor perfusion, tachypnea, respiratory distress, poor feeding, lethargy, rapid progression to heart failure, and shock. Complications if untreated. This is considered fatal in the first days of life to week without proper intervention. Your management. We need to have prostaglandin E1 to keep that PDA open. We want to avoid giving too much oxygen because it can lower pulmonary vascular resistance and steal blood away from the systemic circulation. We want surgery, which is done in stages. So we do a Norwood procedure in the first week of life, which reconstructs the aorta and connects it to the right ventricle. Then we do a Glenn procedure in 4 to 6 months, which connects your SVC to your pulmonary artery. Then at 2 to 4 years, we do our Fontaine procedure, which routes all systemic venous blood directly to the pulmonary arteries. Some families may choose a heart transplant instead of stage surgeries. As nurses, we need to monitor perfusion and oxygenation, careful balance of oxygen, support families through high stress and decision makings. So with hypoplastic left heart syndrome, the heart did not develop on the left side. The right ventricle has to do all the work, and survival depends on keeping the ductus arteriosus open. Without prostaglandin and stage surgeries, babies will not survive. All right, now we're going to go into heart failure and pulmonary hypertension. Hemodynamic and neurohormonal changes in heart failure. Why does it happen? So when the heart cannot pump enough blood, we have low cardiac output. The body activates backup systems to keep the blood moving to the brain and the other vital organs. These are called compensatory mechanisms. So our sympathetic nervous system becomes activated. It's your first response, and we start our flight or fight system. which means the heart's going to beat faster. We're going to have tachycardia. It's going to squeeze harder, and the blood vessels tighten up, and all that's going to increase our afterload. This works for a short time, but tachycardia increases oxygen demand. We have less filling time, which equals less effective pumping. Then we have our kidneys who start to sense less blood flow. And when the kidneys note there's less blood flow, they activate the RAS system, which is the renin-angiotensin-aldosterone system. This causes the body to hold on to sodium and water. This increases blood volume, which helps cardiac output temporarily, but in the long term, it'll lead to fluid overload, congestion, and worsen of heart failure. Our pulmonary system effects, as we have extra fluid, it backs up into the lungs. Children develop pulmonary edema, tachypnea, retractions, and difficulty oxygenating. Frequent respiratory distress is a hallmark of heart failure in pediatrics. Eventually, we'll get myocardial remodeling, which means that the heart muscle atrophies and thickens or dilates to keep up with the workload. At first, this helps, but over time, the muscle becomes stiff and inefficient. This makes heart failure progressive if untreated. These compensatory mechanisms help early on by keeping perfusion to vital organs, but long term they become harmful, worsening congestion, oxygen consumption, and heart strain. Treatment is needed to break the cycle and prevent further damage. So, when a child's heart starts to fail, the body speeds up the work of the heart and holds on to extra fluids to keep blood flowing. At first, it's good, but eventually it's bad and it makes the heart failure worse. So, our manifestations of heart failure in children. Your general overview. In children, the first signs of heart failure are often very subtle. They may not look like the classic adult symptoms. Instead, we think about how the heart and the lungs are working together and how the child eats and how their body's perfusing. So, our respiratory symptoms. We're going to see tachypnea or rapid breathing. In our infants, they could breathe 70 to 100 times a minute, even when they're resting. They're going to have dyspnea. It's going to be noticeable, especially during any activity or feeding. Parents will say their kids just don't have as much energy as their peers, and this happens because the extra fluid backs up into the lungs, making oxygen exchange harder. Nutritional signs. Feeding is one of the hardest jobs for an infant. It's kind of considered their exercise test. Babies with heart failure might take longer to feed, have stops or rests during feeding, and they're going to burn more calories than what they can take in. Parents may say the infant is always hungry and never satisfied. Over time, we're going to see failure to thrive with poor weight gain, irritability, and growth delays. Older children may complain about poor appetite, stomach pain, or getting sweaty when eating, and this is related to the poor circulation in the abdominal organs. Other clinical signs we're going to see, we might hear a gallop, which would be that extra heart sound. We might see some periorbital or facial edema, hepatomegalia, splenomegalia, mottled skin, cyanosis or pallor, weak pulses, cool extremities, decreased urine output, delayed capillary refill. And in our older children, we might see neck vein distension. It's not commonly seen in infants. So your key points here in pediatrics, early heart failure signs are really easy to miss. So we're going to have rapid breathing, trouble feeding, maybe sweating and poor growth or irritability. Nurses really need to listen closely to parental concerns because if they're going to be the ones that notice these subtle changes first. Manifestations. So when we talk about pulmonary congestion or left-sided heart failure, we're looking at the lungs. So we're going to think tachypnea, dyspnea, retractions, grunting, nasal flaring, frequent respiratory infections, and orthopnea or difficulty laying flat. Difficulty breathing while laying flat. If we have right-sided heart failure, this is more systemic. So we're going to have hepatomegaly, peripheral edema, and ascites and weight gain. Everybody's going to have impaired cardiac output with tachycardia, weak pulses, prolonged capillary refill, pale mottled skin, fatigue and irritability, decreased urine output, poor feeding, sweating with feeds, and failure to thrive. So your nursing care for these guys, your general role as the nurse. Children with heart failure may look stable or they could be very critical ill in intensive care unit. We want to make sure that we're reducing the strain on the heart, supporting oxygenation and nutrition, and providing emotional support to both the child and the family. The objectives of the nurse are the same across all ages, but specific interventions may differ based on whether the child is an infant, toddler, or older. We want to monitor our vital signs, our cardiovascular assessments, and our respiratory status. We want to recognize worsening of symptoms like increasing tachycardia, tachypnea, poor feedings, moving to diaphoresis with feedings, moving to not feeding, irritability, going to fatigue, to decrease responsiveness. These are all indicators that the heart is under more strain. We want to make sure that we're assessing our histories and our ongoing data collection. How's the feeding patterns? How long does it take? Are they resting while they're feeding? Are they sweating? We want to know what their growth and nutrition. Are they gaining weight appropriately or are they falling off their growth bands? We want to monitor for a history of frequent respiratory infections. We need strict I&Os. Heart failure often needs diuretics, and it's so critical to track urine output carefully. If we have decreased urine output, it may indicate a worsening perfusion or renal compromise. So we should be doing daily weights, and this should be done in the morning. We want to report even small daily increase. With an infant, if they have greater than 50 grams in a day, or a child greater than 0.5 to 1 kilogram a day, it could be a sign of fluid retention and worsening of heart failure. So our key teaching points: the nurse, it's your job to be an early detector of deterioration. We have to do careful assessments of feeding, growth, weight, and subtle changes in respiratory or cardiovascular status. At the same time, we need to support the families emotionally, since caring for a child with heart failure can be very overwhelming. Pulmonary hypertension. Pulmonary hypertension is an abnormally high blood pressure in the blood vessels of the lungs. Specifically, pulmonary artery hypertension, PAH, is diagnosed when the mean pulmonary arterial pressure is greater than 20, and normal is about 15. PAH increases strain on the right ventricle, eventually leading to right-sided heart failure. Causes of pulmonary hypertension: our pulmonary artery hypertension can be hereditary, so genetic, passed down in the families. It could be idiopathic with no known cause, or it could be secondary due to chronic low oxygen, seen in our chronic lung disease, airway obstruction, or low oxygen triggers like pulmonary vasoconstriction. And then pulmonary venous hypertension is caused by back pressure from the left side of the heart. Examples of this would be left-sided obstructive lesions like aortic stenosis, corrugation of the aorta, or hypoplastic left heart syndrome. Also, connective tissue disorders that affect the blood vessels' elasticity. These lead to left-sided heart failure, which then raises pressure in the pulmonary veins and capillaries. So your key points: pulmonary artery hypertension is a lung problem due to tight or diseased pulmonary arteries, which leads to right heart failure. Pulmonary venous hypertension is a heart problem. The left heart cannot pump, which makes backflow into the lungs and left-sided heart failure. So pulmonary hypertension means high pressure in the lung blood vessels. It can be caused by pulmonary disease, pulmonary arteries, or by back pressure from left-hearted problems. Either way, it strains the heart and causes heart failure. The pathophysiology in infants with large left to right shunts like VSD, PDA, AVSD, extra blood floods the lungs. This causes reversible pulmonary vasoconstriction and increased pulmonary artery pressure early on. Over time, the pulmonary arteries are constantly stressed. Vessel walls thicken, vasoconstriction becomes irreversible, and blood vessels may even become obstructive. When this happens, the shunt reverses direction. The blood flow from right to left instead of left to right. This is called Eisenberg's syndrome. At this stage, blood bypasses the lungs and deoxygenated blood goes to the body. Your clinical manifestations: the child who was once pink with a left to right shunt can suddenly become cyanotic. So they're going to have cyanosis, dyspnea, polycythemia, because we're making more red blood cells to carry oxygen, which puts them at an increased risk for clotting and stroke, and heart failure, especially in children with large VSDs where pulmonary pressures are high but resistance is initially low. Once irreversible, the condition is very serious and difficult to manage. So our medical therapy, we can give digitalis to support contractility, calcium channel blockers and vasodilators to reduce pulmonary pressure, diuretics to reduce fluid overload, warfarin to reduce clot risk with the polycythemia, and supplemental oxygen. The oxygen helps but does not fully normalize saturations. We can do inhaled nitric oxide, which is an effective vasodilator, especially in persistent pulmonary hypertension of newborns. Lifestyle considerations like avoiding strenuous activity and high altitudes, as these will worsen hypoxemia. Surgical repair, timing is critical. Defects should be repaired before irreversible pulmonary vascular disease develops. Large left to right shunts are usually repaired in the first 3 to 6 months to prevent progression. So your key points, these were left to right shunts that started as too much blood to the lungs. They were considered acyanotic lesions, but when they're left untreated, pulmonary vessels remodel, and then we get our right to left shunt, which makes them cyanotic. Prevention is key. Acquired heart diseases. So acquired heart diseases refer to heart conditions that developed after birth. Unlike congenital heart disease, these are not present at birth but occur due to infection, inflammation, or muscle disease. They can affect normal hearts or children that already have underlying congenital heart disease. Examples are cardiomyopathies, which are diseases of the heart that make it weak or stiff, which can lead to heart failure and arrhythmias. Kawasaki's disease, which is inflammatory illness in young children that cause coronary artery aneurysms if untreated, and rheumatic fever, which is an autoimmune response to strep, which can lead to damage to the heart valves, especially that mitral valve. So Kawasaki's disease is an acute febrile illness in children that causes generalized inflammation of the blood vessels. The exact cause is unknown, but we usually link it to infectious or toxic trigger. It's the leading cause of acquired heart disease in children in the United States, and we look at it as immune response. So we have a trigger, either an infection or a toxin, that starts an immune system reaction in the child. The immune system response targets medium-sized arteries, especially your coronary arteries. Both T lymphocytes and B lymphocytes infiltrate the vessel walls. This process specifically attacks the smooth muscle layer of the arteries. The edema and inflammation occurs, swelling in the artery walls, Progressive inflammation weakens the vascular walls. This damage can form an aneurysm, which is a balloon-like dilation. Later, the body tries to heal the fibrinous connective tissue, which causes thickening and scarring of the vessel. Final progression, the weakened inflamed vessels are prone to clot, thrombus formation. Increased platelet count during viral illnesses worsens the risk. Children can develop myocardial infarctions, coronary artery aneurysms, and in severe cases, sudden death. So the key points, Kawasaki's disease starts as a febrile illness but can lead to serious life-threatening coronary artery complications. Early recognition and treatment is needed to drastically reduce the risk of aneurysms. So in our acute stage of Kawasaki's disease, kids are going to have a really high fever, red eyes, a strawberry tongue, rash and swollen hands and feet, and big neck nodes. These symptoms mark the peak inflammation stage. In our subacute stage of Kawasaki's disease, the fever is gone, and the kids might have skin peeling to their hands, their fingers, and their toes. They may be irritable, they may have joint pain. This is the highest risk period to develop the coronary aneurysm, so nurses need to monitor closely. Cues will be changes of echocardiograms and labs looking at their C-reactive protein and their erythrosedimentation rate, so two inflammatory markers. We also want to note their neutrophil counts and their platelet counts. Most symptoms have kind of resolved during this period, so we just need to make sure that parents realize, no, we're still sick. In our convalescent stage, this begins as the child really appears to be fully recovering now. However, we consider this stage to last until the erythrosedimentation rate returns to normal, which could take 6 to 8 weeks. By this stage, visible symptoms have resolved. Children may develop deep transverse grooves in their fingernails or toenails. These are called Bowes lines, and they're evidence of slow nail growth during the illness. Irritability is going to improve, but fatigue may persist, and we need to have cardiac considerations. So even though they look better, cardiac risk remains. Coronary artery aneurysms that formed in the subacute stage may still persist, and we could have long-term risk of aneurysms that may rupture later in life, or giant aneurysms can lead to coronary artery stenosis or ischemia. Patients with cardiac complications will need lifelong follow-up. And as the nurse, we want to reinforce to the parents that they're not cured just because their symptoms gone. They need to have their ongoing cardiac monitoring and follow-ups and medication compliance. So what does that look like? For our care, our overall focus is going to be minimizing vascular damage by carefully monitoring and supporting the child. Your therapeutic goal is to prevent or reduce coronary artery damage, which is the most dangerous complication of Kawasaki's disease. Our therapeutic management involves IVIG and aspirin. We do high-dose IVIG given within 10 days of fever onset, which significantly lowers the risk of the coronary artery aneurysms. High-dose aspirin in the anti-inflammatory range is given until the fever resolves. After the fever subsides, we switch to low-dose aspirin for antiplatelet therapy for 6 to 8 weeks. If coronary abnormalities are present, low-dose aspirin may be continued indefinitely. Corticosteroids are considered if the child does not respond to IVIG and aspirin, but research evidence is limited. So your nurse monitoring in your acute phase We're going to be watching heart rate, respirations, blood pressure, O2 saturation. We're going to be on the lookout for signs of heart failure like tachycardia, tachypnea, and poor perfusion, hepatomegaly. We want to monitor for chest pain, shortness of breath, decreased activity, and reduced tolerance. Other assessments: eyes, mouth, and skins for sign of infection, joints for redness, swelling, and tenderness because they might have arthritis with this. Weight, intake, output all need to be tracked closely, especially if diuretics are prescribed. Family support. Kawasaki's disease is frightening for families. Emphasis that early treatment dramatically lowers complications. We want to provide teaching on medication schedule and importance of follow-up, signs of cardiac complications, and when to seek emergency medical care, such as severe chest pain, fainting, or difficulty breathing. So, key takeaways: nursing care for Kawasaki's disease means preventing heart damage, monitoring the heart closely, giving the IV, IG, and the aspirin on a schedule, watching for heart failure and support, and early treatment saves lives and prevents coronary aneurysms. Patient education, right? Importance of follow-up is key. Even after discharge, ongoing care is essential to recovery and prevention of complications. Families need to know what to expect and what warning signs need to be watched. Expected symptoms during recovery: irritability may last for 2 months after illness begins. Peeling of the hands and feet is very common. Joint pain and stiffness may persist, may be worse in the morning and after naps or in cold weather. These are all part of recovery process and should be explained to family. Monitoring at home. Parents should record the child's temperature daily until the child has been afebrile for several days. They need to notify the pediatrician if the temperature rises to over 101. Medication and safety teachings. Aspirin therapy is continued for weeks or months as prescribed. They need to watch for signs of toxicity, like ringing in the ears, headaches, dizziness, and bruising. They do not give aspirin if the child has been exposed to chickenpox or flu for the risk of Reye's syndrome, and they need to contact the physician of that. Monitoring for bleeding, nosebleeds, coughing, vomiting blood, blood in the urine or stool, unexplained bruising, bleeding while brushing the teeth, all signs of increase issues with clotting due to the aspirin, so they would need to contact the physician. Activity restrictions. They shouldn't be on contact sports if they're on aspirin or anticoagulants due to bleeding risks. Cardiac complications. When to seek help. Watch for signs that may indicate coronary artery involvement. So chest tightness, chest pain, cool pale extremities, abdominal pain, nausea and vomiting, extreme irritability, restlessness, or inconsolability. Vaccine education. We need to avoid our MMR and our varicella vaccines for 11 months after IVIG therapy. Antibodies from the IVIG can interfere with the vaccine effectiveness. And teaching, remember, Kawasaki's is a long recovery process. Nurses need to prepare the families to monitor for fevers, watch for signs of aspirin effects and risk for bleeding, limit risky activities, and recognize cardiac warning signs. Ineffective endocarditis. Ineffective endocarditis is an infection of the endocardium and the cardiac valves. It's usually caused by a bacteria, but it can also be due to a fungal or a viral. It leads to inflammation and tissue destruction of the heart. So the pathophysiology. In congenital heart disease, we have abnormal pressure gradients inside the heart that can damage the inner lining, which is your endocardium. This injury creates a site where platelets and fibrogen form a small clot. If bacteria are present in the blood, they can attach to this clot, create a vegetation. The vegetation grows fibrin, platelets, and microorganisms, which all accumulate, and consequently, the vegetation itself can damage the valve and destroy nearby tissue. Pieces of it can also break off and create an embolus, which can travel to any part of the body, causing an infarction or a stroke. Your key takeaways: infective endocarditis develops in children with congenital heart disease. It can also develop with dental issues, prior damaged heart valves, poor dental hygiene. We see it with IV drug users. The danger comes from the vegetation that destroys the valves and can break loose, causing an emboli. So, ineffective endocarditis is an infection on the heart's inner lining or valves. It often starts after bacteria enters the bloodstream. Bacteria stick to the damaged heart tissue, form clumps called vegetations, and those can break off and cause strokes or organ damage. Clinical manifestations can be very different from child to child. The presentation depends on the organism causing the infection and how the child's immune system responds. The variability is one of the reasons why diagnosing this can be very challenging. Most common symptoms is going to be fever. We can get some non-specific things like anorexia, nausea, fatigue, and malaise. And then depending, your child could have joint pain, chest pain, signs of heart failure, petechiae. We can start to get neurological involvement if we have an emboli break off, which could lead to stroke-like symptoms, seizure, or focal neurological deficits. Child could develop a heart murmur. So your key takeaways: symptoms are often vague at first with fever, malaise, and over time, more serious complications appear like heart failure, embolotic event, and newer changing murmurs. Nurses need to listen carefully to families who are going to report those subtle changes and monitor cardiac assessments closely. Your diagnosis for this relies on blood cultures being the gold standards and an echocardiogram, which will show the vegetation. The echo will show those infected clumps of bacterias. We need to make sure that we're doing good dental care to prevent measures for children that are at risk. Nurses should emphasize prevention during family educations because this can be devastating, but it's preventable. Therapeutic management. Prevention is key. The best is avoiding it altogether. So children at risk with congenital heart disease, valve replacements, or previous history of this should maintain excellent oral hygiene to reduce periodontal infections, receive antibiotic prophylaxis before dental procedures or surgical procedures. And the American Heart Association has guidelines on that. Once diagnosed, this is going to be a long-term course of antibiotics, usually IV antibiotics for 4 to 6 weeks, and then surgery may be required if valve destruction is severe or if the infection does not respond to antibiotics. Next, we have rheumatic fever. So rheumatic fever is a diffuse inflammatory disease of connective tissue. It's thought to be autoimmune in origin. It can affect multiple systems, so heart, joints, skin, brain, blood vessels. The most serious complication, though, is rheumatic heart disease, where permanent damage occurs to cardiac valves, especially the mitral valve and sometimes the aortic valve. Rheumatic fever usually develops 2 to 6 weeks after an untreated or partially treated group A beta hemolytic streptococcal throat infection. Children may not have any signs of the strep throat infection. Not every strep infection leads to rheumatic fever, but when it does, the immune response is abnormal. The biggest risk is the development of the valvular heart disease that may persist for life. So the pathophysiology. We have a strep throat infection in the pharynx, which triggers an abnormal immune response. The immune system produces antibodies and immune cells that mistakenly attack the child's own tissues. This causes inflammation in the heart, joints, skin, and brain. This disease itself is usually self-limiting, but long-term consequences is scarring and deformities of the heart valves, especially in the mitral valve, which can lead to chronic heart disease. There is a genetic predisposition that may play a role, but it's not really conclusive. So your key points: untreated strep throat can cause rheumatic fever, which can cause permanent valve damage with your mitral valve. Early recognition and a full antibiotic treatment of strep infection is best for prevention. So your general overview, this can affect many organ systems. Arthritis is the most common, but carditis is the most significant because of the long-term heart damage. So arthritis is seen in about 75% of cases, and it usually occurs within the first 1 to 2 weeks of life. Carditis is the most severe. It's going to be inflammation of that endocardium, myocardium, and pericardium. It may be silent or have subclinical signs, or we might have signs of a new murmur, cardiac enlargement, heart failure, pericardial rub. Mitral valve is the most commonly effective, and it will lead to long-term valvular disease. When carditis is critical, when arthritis is the most common, carditis causes the most morbidity and mortality. Long-term consequences equal chronic valvular heart disease. So therapeutic management is making sure that we have our full course of penicillin to eradicate the group A strep. We want to manage inflammation and symptoms, aspirins or nonsteroidals for arthritis and fever, corticosteroids. If heart failure develops, we're going to use digoxin, diuretics, and ACE inhibitors. Long-term antibiotic prophylaxis also is key, and we'll talk about that more on this next slide. So once we have a immune response to the strep, we want to prevent any recurrent strep infections because there's high likelihood that we'll have more cardiac damage. So these children will go on monthly IM penicillin, is considered the golden standards. Oral medications are alternatives but require strict adherence. So why prophylaxis matters? The biggest danger in the rheumatic fever is reoccurrence of a strep infection. Each new infection can trigger another immune response, creating more inflammation, which will create more damage to the heart and affect that mitral valve. If there's existing valve damage, repeated infections can make it much worse. So the duration of the prophylaxis, if the heart valve is effective, if the heart valve is affected, prophylaxis might be lifelong. Without valve involvement, the life of prophylaxis depends on the severity and age. It's usually for about 5 to 10 years. The drug of choice is going to be that IM penicillin because it's considered the most reliable method. Alternatives to the injection, we can use oral penicillin, or if we have an allergy to penicillin, we can use erythromycin twice a day. Your nursing role is to teach the families that prophylaxis is not optional. It's essential to protect the heart. Reinforce the importance of timely injections or strict adherence to oral regimens. Monitor for signs of allergic reactions, infection reoccurrence, and cardiac symptoms. Cardiomyopathy. So cardiomyopathy in children is a disease of the heart that makes it harder for the heart to pump effectively. It's classified into 3 types based on how the ventricles look and work. We have dilated, hypertrophic, and restrictive. With dilated, we have a weak and big heart. With hypertrophic, we have a thick and stiff. Those are high at risk for sudden death. With restrictive, we have a normal size, but it's stiff and it can't fill. All three can cause heart failure and dangerous arrhythmias in children. Our hypertrophic cardiomyopathy, HCM. Diagnostics. We can use an EKG, which may show left ventricular hypertrophy with deep Q waves and ST wave abnormalities. Holter monitors will show silent asymptomatic ventricular dysrhythmias. A chest x-ray might show mild cardiomegaly or an enlarged cardiac silhouette. Our general interventions and medications, we're going to use activity restrictions. These children should avoid strenuous activities and competitive sports. They are all at an increased risk for sudden cardiac death. Medications, we can use beta blockers or calcium channel blocker like verapamil, which are going to reduce hypercontractility, decrease left ventricular outflow tract obstruction, and improve diastolic filling. Beta blockers will help prevent dangerous ventricular arrhythmias. They may be prescribed even if they're asymptomatic, especially if we have a history of sudden death. Surgical management, we can do a septal myectomy where we have a surgical removal of part of the thickened septum. This relieves outflow obstruction and improves symptoms. It has low surgical mortality risk. However, it does not lower overall mortality of the disease. We can have a pacemaker and defibrillator insertion. The pacemaker insertion creates a desynchronous ventricular contraction, which decreases the obstruction, and an implantable defibrillator for children with life-threatening dysrhythmias. So your key teaching with this, HCM is dangerous because of outflow obstruction and risk of sudden cardiac death from arrhythmias. Treatment focuses on activity restrictions, medications, and surgery. Even children with treatment are going to require lifelong monitoring. So this is just some medication stuff. Digoxin is a cardiac glycoside that strengthens heart contractions and improves cardiac output. It's commonly used in children with heart failure and certain dysrhythmias. Always assess the apical pulse for a full minute before giving digoxin. We withhold digoxin if the apical pulse is less than 90 to 110 in infants and young children or less than 70 in older children. Typically, it's less than 60 in adults. We want to double check the prescribed dose to ensure it's age appropriate and safe. If the prescription seems unclear or unusual, we need to clarify with the provider before administering. We have to monitor its therapeutic range, which is very narrow, and if it's over 2, it's considered toxic. Toxic signs in early stages would be poor feeding, anorexia, nausea, and vomiting. We can have cardiac signs of toxicity of bradycardia and dysrhythmia. So we always monitor our digoxin level as ordered and always check our heart rate for a full minute before administering. We also want to have electrolyte considerations. We need to watch for hypokalemia, low potassium, because hypokalemia makes digoxin toxicity more likely and more severe. If a child is on diuretics, it's a high risk and we need to monitor them closely. So your key points, you need to be extremely careful with digoxin because it has a narrow therapeutic range. We need to check the heart rate, we need to verify the dose, and we need to monitor for early signs of toxicity. And this is all essential to keep our kids safe. Your family education for digoxin. So we want to make sure that they're administering it exactly as prescribed to verify the dose each time. They need to use an accurate measuring device from a pharmacist, not a household spoon. They need to give it 1 hour before or 2 hours after feedings to improve absorption. They do not mix it with other medications, foods, or liquids. They need to track the dose on a calendar or dosing logs immediately after giving to prevent parents from giving extra doses or missing doses. If we miss a dose or we have vomiting, if the dose is missed and it's greater than 4 hours have passed, they typically skip it and give the next scheduled dose. If it's less than 4 hours, we give the missed dose of medication. If the child vomits, we do not repeat the dose. They have to follow the pediatrician's instructions. If we have greater than 2 consecutive doses that are missed, they need to call the pediatrician, not just do a double dose. We need to make sure that parents are doing oral care. This medication comes in a liquid form and it's sweetened. So we want to make sure that the child doesn't get tooth decay. So after we administer the medication, we want to do oral care or just give a small sip of water after the dose to clean the teeth off. Teach the parents about safety monitoring. Watch for signs of toxicity, poor feeding, vomiting, unusual sleepiness, bradycardia, or dysrhythmias. Parents should assess the pulse for a full minute before administering it. If the child becomes ill with fever, diarrhea, or poor intake, they need to notify the pediatrician because it might not be an illness, it could be a high dig level. They have to keep the digoxin locked and out of reach. If we have an accidental overdose that's suspected, they need to call poison control. Teaching point, narrow therapeutic range, accurate measurements, correct timing, and strict adherence is all important. Lasix considerations. So furosemide, which is Lasix, is a loop diuretic used to reduce fluid load in children with heart failure. It decreases pulmonary congestion and eases the heart's workload. Monitoring for low potassium is important. Signs of that would be muscle weakness or cramps, irritability, restlessness, and confusion. We can see inverted T waves or prominent U waves on our EKG. An important link with digoxin. Low potassium makes digoxin toxicity more likely and more dangerous. If a child is on both, we need to monitor extra close. We can do potassium replacement with supplements or by encouraging potassium-rich foods such as bananas, potatoes, oranges, spinach, and beans. Your nurse's role, we want to make sure that when we administer the diuretic, it's on time, that we're monitoring our INOs, our weights, and our labs, assessing for dehydration, electrolyte imbalances, and changes in our perfusions. We need to teach the families the importance of lab checks, diets, and toxicity. And that is the end of this lecture.